Let me welcome you once again to this second edition of Cancer Research Africa. It's a podcast in which we're looking at progress that have been made towards cancer control in Africa. And we're particularly interested in focusing on the giant strides that have been made by African investigators and researchers that are resident on the continent of Africa. We want Africans to tell their own story. And that is why we'll be bringing to you outstanding investigators that are making huge contribution to controlling this epidemic on the continent. We have with us today another leader, someone who is really blazing the trail as far as clinical care for cancer is involved in Africa. Dr. Amaka, may we meet you, please?
Hello, thank you so much for having me, and thank you for your kind introductions. At some point, I was wondering who indeed you were talking about. It's not all that more.
About you.
Briefly, my name is Amaka Lasebikan. I'm a clinical oncologist at the University of Nigeria Teaching Hospital in Enugu, where I also serve as the Director of Oncology for our Multidisciplinary Oncology Center. This is a one-stop shop where we aim to treat all patients with cancer in the hospital. So really try to expose the patients to the benefits of the multidisciplinary team. So we have the surgeons, the radiologists, the pathologists, the pain and palliative care specialists, and oncology pharmacists, oncology nurses, everybody really that should be involved in cancer care is domiciled at that center, so that when the patients come, they're actually able to get the best in terms of what we have and what we're able to give. So also, I do wear many hats. I'm also the president of the Association of Radiation and Clinical Oncologists of Nigeria. I'm also involved in AOTIC as a co-chair of the AOTIC Special Interest Group and a council member as an AOTIC Secretary Treasurer elect. And last, but certainly not the least, I'm also the current chair for the African Cancer Research and Control ECHO, which is a community of experts who are really invested in trying to promote the implementation, adoption, and really drive the cancer control plans at their country level. We meet a virtual community, lots of knowledge sharing, exchange that goes on there. We share ideas, what worked, what didn't work, basically trying to strengthen our own, each participant's national cancer care program on the continent.
Thank you very much. So I'm sure our audience can see that it's a big masquerade that we brought today. And so you see that I didn't even do enough justice in introducing you very well. But so let's get straight to the meat of the discussion. Last episode, we had with us Professor Mohammed and Dr. Ladoyinbo. And Professor Mohammed talked about the role of pathology in diagnosis and setting up a population-based registry. And we said that led us to the role of behavioral research and how we could modify the behavior of the population. When all is said and done, it all comes down to someone like you at the clinic. You attend to all kinds of cancer patients. And if you look at this Lancet Commission, it clearly recognized the role that the association that you lead, which is the Association of Radiation and Clinical Oncologists in Nigeria, the contribution that your organization has made in ensuring that the NCCN harmonization guideline for Southern Africa is adopted by Nigeria in such a way that that guideline could be utilized to sort of change the face of cancer care and improve outcome. You are at the table. You see all the sides of this discussion. What is your opinion?
Essentially, before I start talking about the utilization of the guidelines in Nigeria, I do want to stress that getting the patients in early is the key to improve outcomes. And so I think that really investing in studies that understand how to communicate with the patient to really change their health-seeking behavior is something that we should really also think about when we want to improve the outcomes on the continent. So having said that, I'd like to just quickly talk about how the treatment guidelines came into being. It was actually developed by the African Cancer Coalition Network, which is a combination of cancer experts, scientists across Africa, different areas, different specialties, who came together and reviewed the parent NCCN harmonized guidelines, which is developed in the United States, and thought to essentially domesticate it to Africa. Because when we look at the NCCN, the parent NCCN harmonized guidelines, it does have the step-by-step pathway that, as clinicians, we are supposed to, guidelines are sort of like, they are guides, so that you can choose, having the confidence that is based on evidence, and that whatever decisions or whatever recommendations are put in the guideline are supposed to ensure your patient gets the best in terms of what is available. Now, having said that, the parent guideline is far out of reach of most countries and specialties in Nigeria. In this era of molecular studies, personalized medicine, which you are at the forefront of leading, we don't have the luxury of that in most of the African countries. We do need something to really give us the confidence to practice and say that what we're doing is okay. Following evidence based on what is really available. So that's how essentially the African Cancer Coalition Network was developed, and they put together different teams, different subcommittees, looking at different cancer types to try to harmonize these guidelines. And the harmonization process was basically trying to color code the recommendations based on what is available, infrastructure and skill sets that are available on the continent. So if you look at it, it's color coded to black, gray, and blue, depending on regional differences and availability of the skill sets. So last year, during the International Cancer Week at Abuja, the Federal Ministry of Health adopted the NCCN harmonized guidelines because their rationale was that it was based on, first of all, we had a lot of input from Nigeria. There were quite a number of Nigerians who sat on that panel. I was in the breast cancer unit, to harmonize that one. Then we had quite a number of Nigerians across all the various cancer types. So we had adequate representation of Nigerians, and then it was done in such a way that it took into consideration the more readily available facilities across Africa. Of course, they also thought that Nigeria would have what they were recommending. So that was adopted for use by everybody in October last year. And we're supposed to run with it, but I'm sure you know that it doesn't always follow that pathway. There are various steps to really translating the science into the clinics, and that is the beauty of implementation science research. So as of this year, it did look like things were a bit quiet in terms of adoption, utilization, implementation. And so it's interesting you asked this question, because I think that was like last week, our association had a breast cancer symposium. And during that symposium, we really thought to find out where we are with the use of those guidelines. So we had sent out a survey across the country, trying to use the crowdsourcing techniques to find out what people perceived as their barriers and possible solutions to the use, to the adoption and implementation of the guidelines. So when we got the results from the survey, we realized that a lot of people, in fact, most of the questions were basically tending towards adoption. So there were issues at the individual foot soldier level about adopting these guidelines for use. So that was what we discovered before the symposium. And then during the symposium, we carried out a nominal group technique to try to rank the barriers that had been articulated. So we got them together, themed them, put them into various themes, and then put it to the public and asked them to vote which ones they felt were the most important. And once they ranked the top 3, we also asked them to rank the top 3 solutions for each of those barriers. The Ministry of Health was very well represented in the meeting, so they saw, and I think that will inform further decisions and policies that they may need to put in place to really help us with the adoption and subsequently the uptake and implementation of the guidelines.
So, yeah, thank you so much, Dr. Lasebikan. That was outstanding, steps and action that you and your organization you are taking. And so we were focusing the conversation on the key issues, ideas generated and discussed in the Lancet Commission on Cancer in Africa. And one thing that they discussed there is this whole concept of hypofractionated radiotherapy. and the role that it can play in improving access to care for up to, increase of about 400%, particularly for prostate cancer patients. Is there anything that we're doing in Nigeria about this? Or what is your own idea if this could be used to really increase access to prostate cancer care?
So the concept of hypofractionation is not new, but again, the really coming to the fore, I guess, is one of the benefits of the COVID pandemic, because during that period, there were lots of interventions to try to reduce the number of times patients come into the clinic without really disrupting the care and hopefully not affecting the outcome of the service that they are accessing at the time. So in a nutshell, since patients are maybe listening to it, so hypofractionated radiotherapy essentially is where for radiotherapy, we don't give the whole dose, the prescribed dose at once. We fractionate it, which means we give it at small doses every day of the week. And depending on the dose that is required, it may span as much as 4 weeks, 5 weeks, 6 weeks, 7.5, depending. Now with that's the normal, what we call conventional fractionation. Now with the hypofractionation, we are giving an increased dose per fractionation, which is per time that you come in to access your radiotherapy. So at the end of the day, we are increasing the dose per fraction and ultimately reducing the duration. So you see that, for instance, for breast cancer, because a lot of centers have moved to hypofractionated radiotherapy in breast cancer, a regimen that would take 5 weeks, we say 25 fractions, we're now seeing that many centers are offering the same treatment at an increased dose per fraction for 15 times and sometimes 16 times. So that really cuts it down to a 3-week treatment regimen as against 5 weeks regimen. Now that has far-reaching implications. We know that in Nigeria, we don't have nearly enough radiotherapy facilities. So there's always a queue. So what that does is that it reduces the use, the demand for the machine. And so when if you have 20 patients with breast cancer and they have to stay on the machine for 5 weeks, and you are able to reduce it to 3 weeks, so you've gained an extra 2 weeks that you have fresh 50 patients coming in to access that kind of service. So hypofractionation is really something that we should be embracing, particularly in LMICs, low middle income countries, not just for the fact that many studies have shown that they are non-inferior to the conventional fractionation in terms of clinical outcomes, but in terms of patient-reported outcomes, which is a huge measure that we also should be taking into consideration, there also are not very significant differences in that as well. So breast cancer, yes, the new one that it's not as popular, but should be, but it is gaining momentum, is, like you said, in prostate cancer. And so with prostate cancer, the treatment regimen lasts for like 6 weeks, but now we're able to give 16-20, which is like 4 weeks. And as we speak, there's actually a clinical trial going on at Lagos, trying to show the efficacy and the toxicity profile of that procedure here in Africa. So it does have a lot of far-reaching effects. We're looking forward to embracing it. In terms of the statistics that you quoted, it's spot on. It's something that should really be looked into. So we have established now protocols for breast, for prostate. There are studies also looking to see if maybe it's safe and non-inferior for CA cervix. And then I believe that if that comes out and the results are positive, then it really does help a whole lot, because in most of Africa, the incidences are the commonest cancers are prostate, breast, and cervix. So that will really reduce the demand and improve access, with many more people getting in within that same period of time.
Thank you. So Dr. Amaka, touched on the work that is taking place at Lagos, the clinical trial on hypofractionated radiotherapy. Now, I want to find out, the Lancet Commission identified 2 important things when it comes to clinical trial. One is that they're looking at the later phase trial testing that focuses on efficacy, toxicity, dosing, and all of that component of previously approved drug or previously approved therapy. That's on one hand. Another suggestion is that of the non-therapeutic interventional studies, that involves behavioral science, research, psychology, cancer survival, palliative care, and things along that continuum. So what is your own opinion about what we should consider as the low-hanging fruit, particularly when it comes to clinical trial? Because we all agree that we must increase the level at which we conduct clinical trial in Africa, particularly in Nigeria, looking at the patient population that we have and the demand for effective therapy. What is the low-hanging fruit?
I think I agree with the Commission's reports and recommendations, because I don't think we're quite ready for the earlier phase trials. The infrastructure is not there, skilled personnel, and I think that will require a lot of momentum building that before we can play in that space. But in terms of the later one, PKC and toxicity, apart from the Hypo-Africa trial, which is the one looking at hypofractionated radiotherapy in prostate cancer, we also have, that is currently ongoing, feasibility, efficacy, I think toxicity as well, TCH, looking for, that's also for breast cancer. So these are already established, but we really would like to see how they play out in our own patient population. And that's critical because, as you know, I mean, the genomic is different. We are not really seeing the same outcomes as have been reported. And most of the inclusion criteria, even when for the studies that have been done outside of the continent, have really not included the other races. Usually is white heavy, based on maybe location and a host of other issues, So having to domesticate it here in Africa is critical, and it's something that really should be looked on and we should embrace. For many reasons, patient population is there. Many patients are treatment naive. Having these clinical trials domesticated in Africa would also build that capacity that we require to be able to conduct high-level clinical research for us. So many benefits I see with that recommendation, and I really think that this is something that should really be looked at critically. Then, having said that, before I answered the question on behavioral sciences, I think that was last year or so, I looked at patient population, breast cancer patient population, and over 400 patients, I think 98% presented with locally advanced disease. Now, the question was, had you not heard about, screening, self-breast exams, and a good proportion had. So how were you not able to translate that knowledge that you had into action and go to the hospital if you saw something that didn't look quite right, or being able to practice self-breast examinations or even clinical breast exams, or for those that are above 40, go in and are able? It's not something we really are looking at early detection for us in the African region, because we don't want to overburden the system at the end. So, but they had heard of it, but they were not able to put this into practice. So that at that time, it made me wonder, were we talking or speaking what they were hearing, or were we just speaking and they were not hearing, or there was a disconnect? So obviously we need to look into how we are communicating to the patients. Now, we can have clinical trials that look at dissemination, so that we know that we are disseminating the appropriate information that will really ultimately change the health-seeking behavior of the patients. That's one. Mm-hmm. And number two, in terms of screening, prevention, people don't really go. So perhaps we need to conduct a few implementation science trials that will look at which of these packages really would be able to improve the uptake that we see. So there's also a role in the non-therapeutic trials as well as in the therapeutic space. It's something that I think every country would need to take stock. I know that in the Lancet Commission, one of the things they talked about was being able to have a stakeholder engagement to really prioritize what is important to the nation, and also using data, local data that is generated. With this too, one will be able to really map out the areas that need immediate intervention and begin to take steps towards it. So not necessarily either or, but perhaps maybe a balance. But as a radiation oncologist, obviously, I would lean and tilt more towards factors affecting treatment, because if you look at the research data mapping, you find out that we have a lot going on in various spectrums in the cancer control continuum, but not enough in the treatment space. So definitely advocate for treatments, clinical trials.
Thank you very much, Dr. Lasebikan. It's been an outstanding work that you're doing and very impressive conversation that we have had. We are grateful to you for what you're doing. And this conversation has clearly shown that it really takes a village. It's the scientists, the clinician, the government, the patient population. And for the patient and the general populace listening to this conversation, one important thing that we want you to take away is that all the science and the research that we're doing is to improve the clinical outcome. We really want to ensure that we change the face of cancer in Africa and turn down the trajectory. We want to change, we want to wind back the hand of the clock. We don't want cancer to devastate the continent, and we're all working together to ensure that the story turns out to always be good for every individual. And so for us to do this, we need everybody. We need the participation and the support and the contribution of everybody. Till next time we come to you again, my name is Solomon Rotimi, and I'm excited to be your anchor on this podcast. Thank you very much for today.